So should I start?
Yes, I think give it about 30 seconds, 30 to 60 seconds for everyone to just filter into the room.
Oh yeah, I see the numbers going up quickly. So I'll wait till the numbers plateau. Okay, I think we've stayed at this number for a few seconds. We'll get started. So greetings everyone, wherever you are, good morning, good afternoon, and good evening. My name is Kee Park. I'm on the faculty of the Harvard Program in Global Surgery and Social Change. And I just want to say welcome to everyone. Everyone's busy, but this is an amazing conference and we're just all glad you're attending. I just want to let you know that this is being recorded. So if you want to see it later on, you can do that. We do want to encourage participation and Q&A, and in that regard, please use the Q&A function to put in your questions, introduce yourself and type in your questions, and we'll try to get to them as much as possible throughout the discussion. So we're going to get right down to it. We'll start off with an opening remark from Professor Salman Khashoggi from Harvard Global Health Delivery Center. Salman? Oh, you're muted.
How's that?
Now you're not muted. Good.
Thank you, Kee. I appreciate it. Hi, everyone. Good morning, good afternoon. My name is Salman Khashoggi, and I'm the director of the Harvard Medical School Center for Global Health Delivery and professor of global health and social medicine at Harvard Medical School. And it's a great honor for our center to co-host this important set of meetings. I know that over the next few days, you're going to look at how to improve surgical care in the Asia Pacific region, how to finance the care, how to build the partnerships that'll be required to facilitate high quality surgical care in the long term. So I want to spend just maybe a minute talking a little bit about our center and how what you're doing fits within that. You know, the mission of Harvard Medical School is to nurture a diverse, inclusive community dedicated to alleviating suffering and improving health and well-being for all through excellence in teaching and learning, discovery and scholarship, and service and leadership. And the Center for Global Health Delivery, we contribute to this mission through a focus on the last phase of healthcare delivery, figuring out how the fruits of modern medicine can reach people in the communities where they live and work. For many years now, our center, which some of you know has had a hub in Dubai, has been working with the program on global surgery and social change at Harvard Medical School to think about how better to deliver surgical care to all the people who need it. I mean, surgery, the gap in surgery has been a major gap in healthcare and health delivery in much of the world. And I think that over the last few years, we've seen the tide change. And in fact, in recent years, we've seen the momentum build for surgery being a core part of national strategies for comprehensive healthcare delivery to populations. And of course, I think all of us were very pleased when following the resolutions that were passed at the World Health Assembly in 2015, the WHO Western Pacific region made surgery one of their priorities. And this meeting is such an important and significant opportunity to build on the work done at the WHO, the work done by colleagues at Harvard, by the various partners and in various countries, including in the Asia Pacific region, to develop national surgical plans and think about how to turn these plans into reality and on the ground care delivery. I mean, I don't need to tell many of you that for years in global health writ large, people have focused on silver bullets, you know, the relative quick fixes, and that has not required the strengthening of health systems. It hasn't required the capacity to deliver comprehensive healthcare. And with COVID-19, you know, and in so many other areas, we've seen what happens when health systems are weak and healthcare cannot be delivered successfully. So I want at the start of your meeting to compliment you on the hard work that you're signing up for. I think the work you're doing is essential to truly building health for all. And, you know, building surgical care delivery systems is the work that's needed to reduce maternal mortality, to ensure that people receive the cancer care that they need, to give people the trauma care that they need, and so much more. And it's clear that your task in the days ahead, in the months ahead and years ahead, is to lay the foundation for building the necessary systems and thinking about how to engage the necessary stakeholders and foster the type of cross-sectoral collaboration that will make this a reality. And so on behalf of the HMS Center for Global Health Delivery, we're honored to be part of your work. We've been honored from the days when you were meeting at our hub in Dubai to talk about the steps that you were taking to build surgical systems in Southern Africa. And we're also very grateful to be a venue, albeit virtual, as you expand your mission further into the Asia Pacific region. So I wish you Godspeed in your work. Thank you.
Thank you, Salman. I just have to say that the Dubai Center for Global Health Delivery has been an amazing partner to the PGSSC in hosting these events. And for every year, we've been building on the momentum, and here we are in 2021, despite the pandemic, we're still partnering with you. So thank you so much. So our next speaker will address this question of why should we care about surgical care in global health? What difference does it make? Well, I'll argue it's a huge difference. And what's been done about it globally? What's the sort of the current state of play? And there's no one better to speak about this than John Meara from the program in global surgery at Harvard. He was the co-chair of the Lancet Commission on Global Surgery. So John, over to you.
Key, thank you very much. And to Salman, I want to echo your comments, Key, that Salman, thank you very much for your leadership and for allowing us to utilize the Dubai Center early on, and then now the Global Health Delivery Center at Harvard. Those meetings at Dubai were really seminal and really helped our global surgery, obstetric anesthesia, trauma communities move forward and move together. I thought I would go over just a little bit of history for everyone. I think all the panelists will know this history, but for the attendees, just want to review the fact that when you look at surgery historically, certainly in the 20th century, surgery was not historically part of the global health dialogue. And as I said, the panelists, we frequently speak about this, but we began to see this change late in the 20th century, early in the 21st century. And when you look at, for example, 2008, that's when Jim Kim and Paul Farmer wrote that, what is now famous article. It was titled A View from Beyond the OR. And it was interesting to have these two infectious disease experts talking about surgery and giving their perspective on it. And that, of course, is the article that has that famous quote about surgery being the neglected stepchild of global health, which has become so famous. I jokingly say you almost can't go to a global surgery meeting without having someone mention that quote. But it really was kind of a metaphor that galvanized the community. But aside from just that catchy phrase that they mentioned, they also went on to debunk the old and false beliefs about surgery. So the belief that it was too expensive, or that it was really not a priority, or didn't need to be a priority, or that the burden of surgical disease was not large. And they, one by one, went through and debunked all of those old false beliefs. And then, as Salman mentioned, 2015 was really a pivotal year. So you look at what happened in 2015. First, Disease Control Priorities 3 came out. The World Bank published DCP3. And interestingly enough, the first volume was on surgery. So that was quite a statement coming out of DCP3. And then the Lancet Commission on Global Surgery was published later that year. And we all know they called for 6 indicators. They called for the concept of national surgical strategic planning. And then, as Salman mentioned, the WHA resolution, so 6815. And that was the resolution that linked emergency and essential surgical care to universal health coverage. That was an extremely important and pivotal resolution. Now, since 2015, we've seen a rapid growth in research, advocacy, policy work related to global surgery, including indicator collection and these, quote, NSOAPs, the National Surgical Obstetric and Anesthesia Plans. And I'm proud to say the Asia Pacific region has really led the way in national surgical strategic planning. For example, Western Pacific Regional Office included surgery in its last RCM, and they also passed a resolution related to safe surgery. And the Pacific Islands also led the way by initially collecting all 6 of the Lancet indicators, benchmarking those indicators against each other and or with each other, and they published that work so that it was open and transparent. Now the Pacific Islands are working together regionally to create national surgical strategic plans in the broadest sense with WIPRO, in collaboration with WIPRO, looking at the whole surgical ecosystem and all of its components with all of its stakeholders. Now tonight, you will hear about some of this fantastic work. And over the coming 3 webinars, you'll learn about all the work that is underway in the Asia Pacific region. I would like to close by thanking all the speakers and panelists for taking time to get involved with us in this process. And thanks to all of you for joining these 3 webinars. All of you are the leaders who will bring about this change to incorporate surgical care into universal health coverage and the SDGs, and also into the more recent narratives about global health security, pandemic preparedness, and climate change. So I look forward to these 3 webinars. Keith, thank you very much.
Thanks, John. That was perfect. You know, we always talk about WHO as being the key partner, and they should be. But there are other UN agencies that have partnered with us on the global surgery movement, and one of them is the UNITAR, UN Institute for Training and Research. And we're honored to have a statement from Nikhil Seth from UNITAR right now. So let's roll the tape.
Honorable ministers, distinguished colleagues from the Asia Pacific region, and esteemed guests from around the world. On behalf of our team at the United Nations Institute for Training and Research, I would like to welcome you to this important event on strategic planning to improve surgical, obstetric, anesthesia, and trauma care. The importance of investing in surgical care has never been more apparent. As we enter the new year and work together to overcome challenges facing us all, such as climate change and the COVID-19 pandemic, I applaud the region for recognizing and acting on this other urgent need. Many countries in the Asia-Pacific region are now beginning or continuing their efforts to develop national strategies to improve surgical care and health systems overall. This is being done using a broad-based, holistic approach, which will have benefits that reach far beyond surgical care. This is a key step to achieving universal health coverage and meeting the Sustainable Development Goals, both of which are not possible without the inclusion of safe and affordable surgical, obstetric, and anesthesia care. We will see greater progress in reducing poverty and inequality, promoting economic growth, and building strong institutions and partnerships by investing in surgical care. Despite this critical need, many challenges remain. The number of surgical procedures needed falls short in many areas. Large gaps exist in the global surgical, anesthesia, and obstetric workforce. And tens of millions of people face catastrophic expenditure every year, often way beyond what they can afford for simple and complex surgical procedures. Finding solutions to these challenges will require collaboration and partnerships within countries and at the global regional levels. The Asia-Pacific region has demonstrated tremendous leadership by forming strong alliances between countries and sectors to reach these common goals. This example will lead the way for other regions of the world, and I look forward to seeing the impact of this event at the regional level. Along with the Global Surgery Foundation, UNITAR is committed to assist this process of capacity building through training, education, research, and policy development wherever possible. I would like to thank the Harvard Center for Global Health Delivery, the Program in Global Surgery and Social Change, and the Royal Australasian College of Surgeons for working with UNITAR to make this event possible. And most importantly, thank you to everyone in attendance. Your leadership and pioneering efforts will inspire others in the Asia-Pacific region and benefit the most vulnerable populations. Thank you.
Oh, that was amazing. Thank you, Nikhil. So, we just finished a 6-part webinar series partnering with the UNITAR. That was more of a global perspective on national surgical plans and surgical system strengthening. And now this particular webinar series really focuses on the Asia Pacific. And to talk about what that looks like from a surgical society's point of view, we have Dr. Liz McLeod as our next speaker. Over to you, Liz.
We know surgery is an indispensable and indivisible component of UHC, and to achieve UHC, we must scale up surgical care. While the data we have is not perfect and there are many gaps, we do have data. We've been through a number of phases of advocacy since Dr. Marla's words in 1980. We've demonstrated cost effectiveness and dailies. We've calculated the global burden of surgical disease. We've collected the Lancet Commission metrics showing critical access and workforce issues in our region and high rates of impoverishing and catastrophic expenditure related to accessing surgical care. We've more recently shown that surgery and anaesthesia care is necessary in around 30% of all hospital admissions. And yet progress has been painfully slow, and we've struggled to mature from the neglected stepchild of public health into a fully recognised and funded contributor to health. Be useful to reflect on why this is so. Surgery requires complex ecosystems with multiple actors and components to perform well. Maybe it's just too hard to create narratives that resonate. In 2015, using a framework they developed a decade prior to compare the relative success of maternal and child health programs, Schiffman and Spiegel examined the movement to advance surgery globally. They found that our main block points are related to leadership and failure to present an organised front, with limited effort to enlist the voices of patients and civil society. Large differences among us exist on even how to address the problem. The classic is the JICS meeting I attended 3 years ago in Vellore, where after 3 days of robust discussion, we were unable to settle on a group of paediatric bellwethers. This lack of coherence has hindered effective positioning. The Western Pacific is fortunate already to have very strong surgery anaesthesia leadership. Collaborations exist, for example, the G4 Alliance and JICS, and these can be strengthened. However, we're at the intersection of a number of crises: climate emergency, the pandemic, and our failures of liberal democracy. Fiscal space for surgery is already tight and is likely to close significantly as health resources are reallocated to these priorities. As SOAs, we need to be strategic, utilising policy windows that may open and looking at the building blocks of strong health systems for synergies. For example, with the Sendai framework for disaster risk reduction, we can look at climate resilient health infrastructure, supply chains, information systems, emergency response teams. And of course, the pandemic, we can look at ICU HDU capacity, workforce, infection control. The horizontal nature of surgery and anaesthesia care is congruent with health system strengthening and the UHC agenda. And as the Lancet Commission for Planetary Health so succinctly puts it, our most likely failure will be a failure of imagination.
Thank you, Liz. And she's also here in person too, so we'll be talking to Liz in a bit. So our next speaker, I'm really pleased to introduce Dr. Takeshi Kasai. Most of you know he's the Regional Director for the Western Pacific Regional Office of the WHO. Not only has he been incredibly responsive to the needs and the requests of the Ministries of Health and ministers, but he's actively facilitated elevating surgical care within his region. And so it's some agenda items. So Dr. Kasai, welcome, and I'll turn the mic over to you, sir. You're muted.
Thank you very much. Can you hear me?
Yes.
Thank you. Good morning and good afternoon and good evening. Especially, I wanted to thank those who connected in the difficult time zone from the difficult time zones. And greetings to the Dr. Poonam Ketalpal-Sin, the regional director for the WHO Southeast Asia region, and to those who are all connected. I very much appreciate colleagues from Harvard Medical Schools, the United Nations Institute for Training and Research, and the Royal Australian College of Surgeons and the Global Surgery Foundation for convening this event. And greetings as well to the honorable ministers and the representative from the ministries of the health participating from our region today. Actually, they are the ones who pushed this agenda up to the regional committee, our governing body meeting. And I'm very pleased to report that the action framework for safe and affordable surgery in the Western Pacific region, which we actually spent about 1.5 years developing, was overwhelmingly supported and endorsed by all member states at last year's regional committee meeting. During the development phase, we listened to the leaders, and many of them said that without safe and affordable surgery, we cannot achieve UHC. We also heard that we need to strengthen and redesign surgical system through broader system approach tailored to local context, so that the people living in the places like outer island and remote provinces can also have a surgical services, and so that specialists can focus on specialized surgical operation. We were also told that we need to set up sustainable training mechanism for clinicians and specialized surgeons. And of course, that many places need more equipment. The regional framework was only possible because of prior work. For several years now, the Lancet Commission on Global Surgery has been a key partner in catalyzing change and defining scalable solutions for provision of quality of care. Member states also adopted the resolution on strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage during the 68th World Health Assembly in 2015. I wanted to really thank all those who put the effort in moving forward at the global level. And our approach in developing a framework was to build on and adapt and tailor this global efforts to our regional context, listening to those leaders and then the Ministry of Health peoples and then the expert voice. Through discussions, we realized that this agenda can be used not only to achieve safe and affordable surgery, but potentially also as a pathfinder for strengthening health system itself. Of course, the COVID-19 pandemic has been posing a challenge to us advancing the action framework as planned. But on the other hand, the pandemic also creates an environment that we should seize. Healthcare services investment has significantly increased, including ICU care and infection prevention and control. We also anticipate it may not continue that long. So we really have to think about how we can use this environment to advance. I hope the regional action framework will bring everybody's effort together, not just advancing safe and affordable surgery, but also building the platform for transforming health system to reach every corner of the region. Thank you again for giving me an opportunity to speak. And I wish you fruitful and productive discussions. Thank you very much.
Thank you, Dr. Kasai. I'm really glad you brought up the nexus between pandemic preparedness and the value that surgical system strengthening represents in that effort. And it's been a delight and a pleasure to work with your team members on the safe and affordable surgery agenda. Our next speaker is by video, and she is Poonam Singh, the regional director for the Southeast Asia Regional Office. And let's go ahead and start her statement.
A very good morning to all. It is a pleasure to join you for the launch of this timely webinar series. The WHO Southeast Asia region has in recent years integrated surgical system strengthening into its overall quest to achieve universal health coverage. Over the past 2 decades, the region has made world-beating progress in reducing maternal mortality, which is, of course, a strong proxy indicator for equitable access to basic and comprehensive emergency obstetric care, which around 15% of all pregnant women require. Accelerating reductions in maternal, child, and under 5 mortality continues to be a flagship priority. Notably, the region is more than halfway through the decade for health workforce strengthening and has made substantial progress in enhancing health workforce density and skills, which is vital to the provision of safe and effective surgical, obstetric, anesthesia, and trauma care. By 2030, the region aims to reach a surgical, anesthetic, and obstetric provider density of at least 0.2 per 1,000 population, which I am certain we can achieve. Commendably, all countries continue to implement national blood policies that are aligned with the global WHO strategic framework for blood safety and availability. Moving ahead, we do indeed face many challenges, but perhaps the most significant of all are the fiscal challenges that will result from the COVID-19 pandemic, as well as expected declines in household incomes. Combined, these could result in a considerable increase in foregone care, as well as in out-of-pocket payments. That is why WHO is urging all countries in the region to not only sustain but scale up public health spending as a percentage of GDP and to also increase financial protection so that access to essential services, including surgical care, can be maintained and enhanced throughout the COVID-19 response, recovery, and beyond. Thailand and Indonesia in particular have demonstrated how increases in prepayment and public financing can deliver sustained reductions in out-of-pocket payments, while India has extended financial protection to upwards of 500 million people for secondary and tertiary inpatient care packages. WHO will continue to support all countries to increase the volume and efficiency of public health spending, including on surgical system strengthening, to achieve maximum impact. Beyond health financing, several priorities must guide the region's onward mission to ensure essential surgical services are accessible to all. First, planning must be conducted on a multi-year basis and consider the entire health sector, including the private sector, as well as other sectors that contribute to health. The adoption of detailed and fully costed sector-wide approaches will facilitate the development of comprehensive, feasible, and sustainable strategic planning, which all countries will benefit from. Second, planning for the provision of specific services must be aligned with and integrated to each country's overarching multi-year health plan. Doing so will avoid verticalization and ensure that surgical system strengthening plans are supported with adequate human resources, medicines, equipment, and infrastructure, as well as strong supply chains and utilities for sterilization, maintenance, and waste disposal. Third, referral systems must be strengthened to enhance efficiency and ensure that optimal care is available at the appropriate level and that resources are used in a cost-effective manner. And fourth, the implementation of monitoring and evaluation systems, including of service quality and patient safety, must be prioritized to ensure that all adverse events are detected and followed up on. Specific efforts are needed to monitor and avoid unnecessary cesarean sections and lapses in infection prevention and control. Ensuring that health services of adequate quality is a core component of UHC and must be central to our shared effort to strengthen surgical systems in the Southeast Asia region and across Asia Pacific. I wish you all the very best in the coming webinar series and look forward to building momentum in this crucial area of work. Thank you.
Thank you, Dr. Singh. It now gives me great pleasure to introduce our panelists, and just a very brief introduction. Their biographies are more explicitly outlined in the material you will have received. Just to say that we've got very significant firepower here tonight. We've got many, many decades of experience in public health and surgery in the region. And so first up, it gives me great pleasure to introduce Dr. Howard Sobel from the Western Pacific Regional Office in Manila. Howard is the lead of quality and safety, infection prevention and control, and maternal and child health at the WHO in Manila. And he's been more recently allocated the brief of herding the surgical anaesthesia obstetric cats in the region following on from the RCM. Howard, thank you.
Thank you very much, Liz, and to the organizers. Good morning, good afternoon, and good evening. It's a great pleasure to speak at this panel. I'm going to apologize in advance that I can't use video because I'm basically quarantined at home, and and I keep getting cut off every time that I exceed a certain bandwidth here. So you're going to just hear my voice. As Dr. Kasai, our regional director, mentioned, the action plan, the action framework for safe and affordable surgery in the Western Pacific region was endorsed at the 71st session of the Regional Committee of the Western Pacific last year. The framework seeks to translate global commitments to the regional level after listening to the needs and ideas of our member states. Also, our RD mentioned this. The framework outlines an approach based on 4 operational shifts by which to identify actions to deliver safe and affordable surgery in the short, medium, and long term. The operational shifts involve establishing a shared vision for surgical care by stakeholders within and beyond the health sector, redesigning health systems to develop strong surgical ecosystems, and regular monitoring and recalibration of the shared vision. A critical aspect of the systems redesign approach is that health system inputs such as staff and medicines, essential supports such as supply chains and sterilizations, and processes such as quality and safety mechanisms are all considered together rather than as siloed approaches. In addition, I think it's important to acknowledge that often change starts local before being replicated and scaled up nationally. In Japan, for example, safe and accessible surgical services have been built from the district and facility levels up based on local epidemiology knowledge and priority setting. We need to consider different models when seeking to strengthen surgical care. The third and last point I would like to share is around finding the hook or entry point for securing commitments towards safe and affordable surgery. I've had many discussions with the regional director and others, and one of the things that keeps coming up is we need to find things that are tugging at people's hearts, and in addition to feeding the brains. One of the most successful programs in newborn care I'd like to just mention, we created here, and what made it so popular is the health workers and mothers alike saw pinker, healthier, and happier babies with what we taught. We need to find those equivalents for safe and affordable surgery. This is a little bit different than was mentioned before about quick fixes. This is quick wins that are highly visible that bring our stakeholders together. We look forward to working with partners in the region, including the host of this meeting, to support member states to achieve universal access to safe and affordable surgery. Again, I thank the host, not just for this meeting, but for all the commitment and heavy efforts that they're putting in to make this agenda work. Thank you very much. And I'll be happy later to answer specific questions on the panel.
Thank you, Howard. Next up, it gives me pleasure to introduce Lord Viliami Tangi, who has been the Chief Surgeon in Tonga for many years. He's also a politician and has served as the Minister for Health in Tonga for 12 years, and also he has served as the Deputy Prime Minister. So he brings enormous experience both in politics and medicine to this forum. Thank you, Lord Tangi.
Thank you very much, Liz, and it's really my very great pleasure. Thank the organizer for getting me to take part in this very important session. And I'm particularly very pleased to be around the last so many years and for the next number of years, hopefully, because the change that I have seen, the impact of this work on surgical global indicators that's been on the table and all of us are working on, is really a way forward for the world. As Liz mentioned, I was very fortunate to be in politics for some time. And I was continuing to do surgery all those years. But most of the time we're busy. We're busy doing our own things, doing here and there, but and the focus and the global level, we continue to miss this very important message that Lancet Commission came about and exposed to all of us. I mean, all those years I did not know what is the number of, say, SAOs that my little country need. Now we all understand it. And to me, this is a marvelous opportunity for all of us. And I would say that the time is not long, because the emphasis will keep moving. Emphasis keep moving, especially for politicians. New politicians will come along. But the opportunity that we have, and I'm very happy to see that WHO is actively and strongly coming and support this move. SPC in our region, Secretary of the Pacific Community, and the REX and all of you. So I'd like to make a plea here that we actually do not have unlimited time for this. We need to make sure that we bring everybody on board. The small, especially the small developing countries, they need our support and our help. Bring them on board. They need all to develop and form their own surgical plans for this. Otherwise, we miss the marvelous opportunity. So I'd like to thank all of you. All of you, we've been working hard on this, and thank you again, and I'll look forward to discuss more with some more questions later. Thank you very much, Liz.
Thank you very much, Bill. Next, I would like to introduce Dr. Muhammad Yusuf bin Abdul Wahab from Malaysia. Dr. Yusuf is a general surgeon with extensive experience in training and education. He's the head of general surgical services for the Ministry of Health now in Malaysia. Dr. Yusuf, thank you for joining us.
Hi, Liz. Thank you, Liz, for this opportunity.
Yeah.
First and foremost, I would like to thank the organizing committee for giving me this opportunity to share our experience in Malaysia as regards to this initiative. I would also like to convey the apologies from our Director General. At the moment, he's very busy, caught up in navigating the COVID situation. In Malaysia, the healthcare delivery is by both public and private sectors. The public is basically funded by the government, while the private is by insurance or out-of-pocket expenditure. Public healthcare facilities cover both urban and rural areas, while the private is mainly focused in the urban areas. So what you see in this slide here is a meeting chaired by our Director General. The people who attended this meeting were all stakeholders in providing healthcare. There were representatives from the colleges, universities, private and public health. This is to introduce as regards to the Lancet Commission finding, and then to pave the way as to drawing up a national plan. So Ministry of Health, being the major provider, we actually formed a 4-member core team for the Global Surgery Initiative. It comprised of the 2 clinicians with 2 officers from the ministry, the national heads of the surgical services and the national head for anesthesia services. So our plan initially was to implement it in 2 phases. In the first phase is for implementation of essential surgical services and anesthesia. Our phase 2 plan is to get the obstetrics and the orthopedics to join the national plan. We came up with schedules for state visits. And the other important initiative we took after the meeting with DG was to make POMR a surgical KPI with standards set at about 90% reporting. At regional level, each state in Malaysia, we have 13 states in Malaysia. And as you know, the country is divided into West and East Malaysia. At regional level, each state is run by a state director. So the initial engagement meetings that we have at the state is attended by the state directors and the hospital directors. After the initial engagement meeting, the core team actually went down to the district hospitals to visit to understand the needs and barriers. The core team will assist with possible solution. And today the core team has completed 5 out of 13 states. We hope to complete looking into the rest of the region by end of the year. A national forum on global surgery was actually scheduled last year, somewhere around August 2020. However, the national forum was deferred due to the COVID pandemic. So the ministry actually hopes to draw out our national plan very soon. As for the surgical indicators, we have yet to get data on out-of-pocket expenditure. This is our current status as regards to the findings of our global surgery indicator. At the moment for Malaysia, we have got 94% coverage. The states which have issues and problems are the state of Borneo. And with this current plan, we hope to be able to address the needs of surgery for people in the Borneo region. Okay, that's all this for the update for Malaysia. Thank you.
Thank you very much, Dr. Yusuf. Next, I would like to introduce the Honourable Dr. Ifiremi Wanganabete, who is the current Minister for Health in Fiji. He's also a surgeon and the current president of the Pacific Island Surgical Association, and brings with him, once again, vast experience in the problems that we're facing. Dr. Wanganabete, thank you.
Thank you. If you can hear me, I just got a presentation that I'd like to share. That's there. Thank you. And first of all, I just want to thank the organizers for these wonderful panels of meetings that's going to be held over the next few months. Thank the Harvard Group and also UNITAR and WHO and also the College of Surgeons who have been supporting us in our growth in the Pacific over a long period of time. Next slide, please. Are we able? Thank you. So I think this is a slide that's beginning to make the rounds around the world now, but this is where we are with the current status in Fiji. The access to surgical care within 2 hours is just sitting just below 70%. We have about 6 per 100,000 of our SAO density, and the surgical volume of just around 1,500 per year, and a post-operative mortality rate, which is quite acceptable, given that we are a small island development state. And we also know that Fiji, with 5 other countries in the Pacific, put their hands up and were involved in the ENSOP that was done here straight after the 2016 Lancet Global Commission that was carried forward. Next slide. The current risk of impoverishing expenditure is just at about 20%, and also catastrophic expenditure. One of the reasons that we have at the moment is the fact that, and I keep on saying this, in small island development states, similar to other countries around the world, maybe in the Africas, the geographical distances and also the challenges in access makes that a challenge that we have to be able to push through. And as I keep on alluding to the fact that Fiji is about 300 islands and 100 of them are inhabited. And so we know that if we begin to do the work that we want to do, that within the next 3 or 4 years, we'll be able to, in terms of access, go beyond 70% and sit at over 80% and somehow reduce that. It will never be zero, but it will be a significant change from where it is now. Next slide. This slide, again, talks about exactly what I've been alluding to earlier, and again, brings to the fore the fact that we continue to train. We are now better in terms of numbers than we were before. I think if you look on the left bottom hand corner, I'm sorry that it's in small print, but you can see that within the last 6 years, we've made significant advances in terms of the active number of doctors that we have within the Ministry of Health services, the nurses that we have, the fact that we have more midwives. And this has all happened within the last 6 years. A lot of things have happened since then. The government has certainly made health a very important part of our nation's priority. We are focused on the SDG goals, especially the ones around health. For example, SDG 3, universal health coverage. There's increase in establishment in terms of vacancies being advertised so that people can fill them as they come through from the institutions. More scholarships have been given and loans to students who want to, dwell into the STEM and especially around the health workforce. And also the training programs, the postgraduate training programs that we have in place. And again, the fact that we have a national university that is where a lot of the health workforce is trained with, apart from the other 2 universities that we have, and also the fact that we have support from the College of Surgeons and the others in our training program. So those, within the last 5 or 6 years, there have been significant increases in those areas. Next slide, please. I think this is, to me, this is the important part of what I want to talk about today, is what have we done, given that we know what the end scope is and where we're heading forward. The pictures on the right, they tell us what we are doing. They're not in theater. These are surgeons who have been combing the hills and the highlands after the cyclones, usually working through the emergency medical team and working, finding surgical patients, dealing with them in the peripheral areas that they are in the field hospitals that we set up, but more importantly, pushing out the public health message. And that, in an essence, is something that we've been doing, and taking the surgeons out of their comfort zone in theater and taking them out into outreach services, making bellwether capable hospitals where there's been a cyclone. We've had about 5 in the last cyclone season. We've also appointed our chief surgeon. He's sitting with me today, Dr. Sheshes Turangapa, who's a pediatric surgeon, with our chief medical advisor, an orthopedic surgeon, Dr. Chemesa Tunrabu. We're working with WHO. We really want to have that collaborating center and the Royal Australian College of Surgeons, and also with SBC, the Harvard Group. We've also been involved with G4 Alliance, and I think we're beginning to develop those networks and strengthen them. And the third one really is the engagement of the surgical doctors in public health response during COVID-19 outbreak and post-disaster response. Next slide. Next slide, please. Again, these are the, what we've done last year when we had, we stopped the training program to get all our staff to focus on COVID-19. We said to the trainees, we said to them, look, you will be trained next year. We want you this year to understand public health. We want you to understand the role of the surgeon in public health, the role of the Pacific surgeon in public health. And there's a picture of one of our, aspiring trainees who's, checking the inside of a container to see if there's larval samples of mosquitoes that could be growing dengue. And also we've gone through a remodeling of our health service provision framework for Fiji. And these remodeling has become very helpful for us. Next slide. So what the remodeling has happened is, and the thoughts around the remodeling have been with us. Our current permanent secretary is also an obstetrician. So we've been thinking about this in many a time as we sat in theater waiting for our cases to be done over the last 20 years, about how we want to make surgery, anesthesia, and obstetrics a public health issue. How do we bring it to the fore? So when we now have the opportunity to be in the forefront, we've been able to bring those lessons and those from COVID-19 and disaster and remodel the health services. We are focused on integration, the integration between clinical and public health. And many public health physicians will say the story that we clinicians, we are at the bottom of the food chain, or we are at the bottom of the river, and the tap is up top. We need to be able to go up to the tap. That's what we want to do. That's what we're doing in Fiji. We're taking our trainees to the top. We're taking them to where the disease happens, so that they can push advocacy there. They can actually being able to meet people, diagnose a hernia, discuss with them, get them 5 minutes down the road to the field hospital, get them operated near home, and then they go home the next day. Decentralizing, focusing on establishing surgical capacity in the smaller health facilities. So we've had a structure where we had 3 main hospitals and about 18 to 20 smaller hospitals all throughout the land. But over the last 30 years, we've gone away from those small hospitals. So they've become GP admissions, and we put everything into the main hospital. So really it's anti-universal health coverage and anti-safe and affordable surgery bellwether concept. So we have actually gone back again, where we wanting the hospitalists to actually run these small 30-bed hospitals. And that's where we are pushing the surgeons. So the initial ENSO required us to actually look at what we were doing in the 3 main hospitals. But now we just recently, the chief surgeon working with the other surgeons have now gone through and assessed nearly 20 of these small hospitals, so that we can actually look at how we can be able to strengthen them, add more value to them, because they are there in the peripheral areas within easy access to those that we meet. And the third one is so important. Services, surgical services cannot develop in isolation without the development of the rest of the health services. And it's vice versa. To move forward, surgery needs the rest of the health service, and the rest of the health service needs surgery. That has to be the message. Next slide. So what are the threats? The threats are competing health priorities affecting resource allocation. This is what's going to happen. COVID-19 is the premier threat at the moment. And I also know that straight after this, there's going to be a significant vacuum in healthcare workers around the world, because a lot of governments and a lot of institutions are going to realize the importance of healthcare workers. And so there's going to be a significant vacuum. People are going to be thinking about, instead of having 7, 10 people working in the ward, then what about those 7 and 10 people actually just increasing it to 12 to 15. So I think worldwide there's going to be a greater need for resources into health. My worry is that there are countries that are going to be challenged, and they're going to actually be affected by this in terms of their moving forward with their ENSO plans. And we have to make sure that we have to be able to bring them along and take them together. Okay? We've got to bring them along and take them together. I think that's important. I think in Fiji, we have the political will. In Fiji, we have those in the know. Fiji is a converted country. It's the other nations we've got to take along, because there's going to be a big so-called black hole in the health arena after COVID, just not during COVID, but after COVID. There's going to be a lot more resources pushed into health. There's going to be a lot more need for human resources, but we've got to make sure it's not only public health. We've got to make sure it's not only for critical care. We've got to make sure it's not only for molecular labs. We've got to make sure that in that discussion, that safe surgery, obstetrics, and anesthesia is part of it. We've got to pitch at the global level that without safe surgery, anesthesia, and obstetrics, we can't have universal health coverage. And my worry is that's going to be the most significant challenge. Okay, the increasing cost of surgical training may limit access, as we're all aware that some of the surgical training programs have gone on to using certain formats such as online in Zoom. We've got to make sure that our surgeons, irrespective of whatever format of training is in place, that we've got the capacity to actually ensure that the apprenticeship model continues. This morning, we've had a meeting with the Dean of the Medical School, in which our trainees have come through. And these are some of the things we discussed this morning. And we've got to continue to maintain the interest and the focus on safe and affordable surgery, obstetrics, and anesthesia. There has to be traction in this space, because as I said, and again, I want to finish with this. If we don't, then we will be back to where we were in the 2016 Lancet Commission. That's the biggest worry post-COVID-19. So I think it's so important that we bring everybody along and we push this at the global level so that we are not back, but we are moving forward. And again, that thing about resilience dividend, I think that's so important, that in the midst of this crisis, we continue to make a gain in safe surgery, obstetrics, and anesthesia. Next slide. I think that's all we've got to talk about. Next slide. I talked about this. Our next generation surgeons must be proponents of public health. They must understand public health, because the public health space really is where WHO and the UN agencies are pitching in, and we must be able to get them to understand how do they pitch surgery in that global space. And surgical training must prepare surgeons to practice and be relevant in the new post-COVID environment, not only in theater, but outside of theater. Next slide.
Dr. Wanganabete, have we got long to go? Because I want to leave plenty of time for discussion.
Okay, 1 minute. Establishing of 5 bellwether hospitals. That's what we're doing now. Strengthen collaboration, continue advocacy for safe and affordable surgery. Next slide. Last one. And last week we celebrated 300 days of being free of COVID-19 in the community. And I think it's so important. What is so important about this slide, Liz, is that you got the public health physicians in that slide being celebrated in Parliament, and the surgeons are out in the community in the slides before, going out and looking for those who've been affected by the cyclones. And I think that's so important. That shows the evolution of what's happening in Fiji. Thank you.
Thank you very much, Dr. Wanganabete, and I really applaud the Fijian approach of getting our surgeons and specialist providers out of our little vertical silos to engage as public health physicians. I think it's really critical for all of us. Thank you very much. A couple of panelists still to go. Now gives me pleasure to introduce Dr. Amir Herman, a public health physician, epidemiologist and general practitioner, also with a political bent from the Cook Islands, where she served as secretary to the Ministry of Health recently. Dr. Herman, thank you for joining us.
Kia ora, and thank you very much for this wonderful opportunity to speak to some very, very key leaders in the surgical space. May I also acknowledge the two prior and current ministers of health from Tonga and Fiji. It's lovely to have such strong leadership in the Pacific that has been very important and contributed to progressing surgical services, at least in the Pacific region, and now extending into the Wipro region and globally. I do note that Kiki is here somewhere, and also wish to acknowledge his leadership and RACS and SPC as well. I think just briefly, we're all here for the same reason, to improve surgical services. And I think one of the things I always think about, especially when you're working in less resource settings, the Cook Islands are a little bit better off resource compared to other countries in the Pacific, but we need to understand that money is not the only issue, but training or access to quality training is a huge barrier for us. If we want to improve our services, surgical services, obstetrics and anesthesia as well, we need to have manpower, and manpower who have had quality training and quality supervision and ongoing professional development. At this point in time, I think, if I'm correct, surgical services might be the most advanced in the Pacific, which is a testament to the Pacific health leaders, surgical leaders of the past, and including the late Sir Tiripa'i Maote. So many people in the past have led the way. And I think the challenge now is how we need to figure out developing a workforce, acknowledging also the Honourable Minister Wanganabete's comments around integrating with public health. It's always lovely to have surgeons talk about public health, and it's important. But the seriousness about this is really the preventative aspects. You know, if you think about the 4 existential threats that we have facing the Pacific, globally, also COVID, of course, right now on our doorstep, climate change, a more significant planetary threat, NCDs, which are the biggest ones that we are struggling with right now in the region, and impacting on surgical services in terms of obese, morbidly obese, comorbidity laden patients sitting on the table weighing 170 kilos or so. And then, of course, antimicrobial resistance. All of these 4 have a lot to do with surgical services and its development. And I think the solutions around this will require health systems to be much more efficient, and human resources development to be much more efficient. Agree with decentralization of health services so that they are closer to the people, and allows us to get a better feel for the needs at the grassroots level. Otherwise, we continue to build these big flash hospitals. But I think at the same time, coming back to funding, it is critical, and hopefully at some point in the future, the Pacific does not have to continue to catch up in terms of we need more doctors, we need more surgeons, we need more public health physicians, we need more renal physicians and so forth, because the workload and the financial burden or the lack of financial support is quite significant. And the more we have Pacific Island countries and governments assigning or allocating more resources to health as per GDP, as well as a proportion of government funds, is going to be important, so that we don't have to have this, what we have the resource surgical services in the future. So really, that's all from me, and I look forward to further discussions later on today. Thank you very much.
Thank you so much, Dr. Herman. Thank you for joining us. And our final panelist is Dr. Bikash Devkota from Nepal. Dr. Devkota is a pediatric surgeon, and he's currently working as the Division Chief in the Quality Standard and Regulation Division of the Ministry for Health and Population in Nepal. So thank you for joining us, Dr. Devkota, and looking forward to your thoughts.
Thank you. Thank you so much. Good morning from here. I am Dr. Bikash Devkota, working as a Chief of Quality Standard and Regulation Division at the Ministry of Health and Population. I have main responsibility for developing standards for healthcare and monitoring of all types of hospital in the country, including private hospitals, and also I have the responsibility for the implementation of minimum service standard in the hospitals. We have also Department of Health Services and provincial ministries for social development, which mainly implement the policy guidance developed by the Ministry of Health. Our national health policy envisions access to basic emergency health services for all citizens and easily accessible specialized services through health insurance. Importance of surgical services is now even more, as NCD, road traffic accidents, diseases like cancer are increasing in Nepal too. Moreover, there are many people waiting here for long for a simple surgery. To address those and respect their right, special surgical care is very important. Nepal has taken as priority for the treatment of chronic diseases requiring surgical care, including renal transplant even with the subsidies. Cesarean section here in Nepal is free of cost. Our national health policy, periodic plan, and health sector strategies of the country also support for the enhancement of surgical care in the country. In this context, we had series of discussions for the strengthening of surgical care in the country. A concrete surgical plan is strongly recommended from different sectors at this moment. And hopefully, with the support of you all, we can have it in near future. Sharing, of course, is a learning, and it has great role for learning in the countries like in Nepal, where the resource is in low setup. I'm very pleased to be here and put some thoughts on the behalf of ministry. I also definitely will learn many things here in this forum. Thank you for making it possible, and we'll be happy to answer questions in panel later on. Thank you.
Thank you very much, Dr. Devkota. And that wraps up our opening statements from our panelists. And as you can see, we've got a very significant amount of not only clinical, but political experience, which I think is going to be crucial to advancing the safe and affordable surgery agenda in the region. So now we've got some great questions coming from our audience, and I'd like to ask Key to get us started with our panel discussion.
Thank you, Liz. So first, let me ask the speakers to all turn on their cameras if they can. We would, and then any other participants to as well, but definitely the speakers, we want to see you. And we'll start off with a question from Dan Peterson. So Dan is the executive director for the G4 Alliance. It's a membership alliance of surgical global surgery community. And he has a very good question. So Dan, I'm gonna actually ask you to turn on your mic and your camera to ask in live. Are you there, Dan?
You're on mute, Dan.
There we go. Thank you, Dr. Park. Thanks to our wonderful panel. And my question is, what can each of the elements of society do to build the political consensus to fund strengthening surgical systems on a sustainable basis? And by segments of society, I mean the governmental segment, the non-governmental segment, patients, providers, funders, the general public. What can they all do to build the political consensus we need to fund strengthening surgical systems on a sustainable basis? Thanks so much.
That's a great question, Dan. You know, how do we build political momentum, and who does what? Why don't we start with Minister Wonka as the first one to respond to this? Did he step away?
No, he's on mute.
He's on mute.
Yeah. Okay. Thank you. Can you hear me?
Yes.
Okay. Thank you. Thank you for that question. Lord Tangi would be more experienced than me, but anyway, I have some reflections. I think the important thing is it requires a platform approach in terms of how do you harness whatever organizations that are in the country to be able to keep moving forward. You know, so what about the medical association? How can the surgeons be part of the medical association? How can they interact in the medical association? What about the medical council? You know, how can the surgeon be part of the medical council? What about the other organizations? There's a Fiji Public Health Interest Group. You know, how do we, so, you know, our surgeons have become interested in that group. So I think it's about doing the groundwork in terms of what are the organizations outside of theater, outside of surgery that we can be part of, and then move from there. Because at the end of the day, and again, Lord Tangi is more experienced than this, it's about political influence is about putting yourself into that space. So if we are stuck in theater, then the ones who will move in that political space will not be able to see us. You know? So that's why, as you can see, one big thing in the Pacific and at the moment with COVID-19 is the public health space. So the thing, the surgeons in the country have said, look, you know, how can we contribute into the public health space? How can we contribute to universal health coverage? And as they do so, the development partners are looking, the politicians are looking, and they're beginning to see how effective the surgeon is. Because we also have to understand that if you talk to the public health physicians, if you talk to the physicians, if you talk to the administrators, they have this view that we surgeons are somehow, stuck in that theater mode. You know, that we think along just being in that theater mode. And it's very difficult for them to be able to understand that we have such a big use outside of theater. You know, and I think it's about us as a group being able to collaborate, being able to network with other organizations, with other stakeholders, and beginning to actually infiltrate into those spaces, because the public health physicians do it very well, more so in the Pacific. And that's why a lot of things that are of interest to them, they're able to raise at the global level. Thank you.
Thank you, Minister Wonka. I do want to go to Lord Vilamitangi. Can you give us your thoughts about how to build the political process?
Thank you very much for this. And then I think this is a very important question. Now, in my experience, all ministers of health of the world want their population and their people to be well and healthy. It is the lack of knowledge and know-how. They sort of limbo in between. So I'm talking from experience. It is our role, you and I, to educate our politicians. I'll give you an example. The minister from Fiji knows this very well. We had our previous minister of health was a surgeon, and he was with me on this exercise, Dr. Saya Pukala. Now, 2 years ago, this was changed with a new minister. Within 2 weeks of that new appointment, I requested a meeting with the new minister. And I sat down and made a PowerPoint presentation on this issue, on this topic. She knew, is a lady, and she knew nothing about this project before she was appointed. Now she's a very strong supporter of this issue here in town. So then sometimes we talk about lack of political commitment and leadership. It is us, it is our role. I tell you this. Get them, sit down with them, explain to them, explain it clearly. And that is how the ministers of health of the Pacific 2 years ago made this commitment for ENSOP for the region. I think that's my short answer to this question there.
Thank you, Bill. We've got a lot of great questions coming in. The next one I'd like to put to the panel, and maybe kicking off with Dr. Sobel. Question from Dr. Waters is, how are we engaging obstetric and gynecological and maternal health care in this setting? Dr. Youssef spoke to this, but it would be good to hear from other countries, and Howard, maybe you could lead us in as an expert in this field.
Well, thank you very much. It's within my original terms of reference, and going back a couple decades. I would like to first say that I think that many of the others can answer this from their own experiences from the ministry side. I'm being asked to start my video. I'd rather not, because I don't want to lose my connection. Anusha. So I think that some of them can give some very good answers to that, but obviously one of the major factors in determining maternal mortality is whether they're able to get reasonably quick access for emergent care. And let me take a step back. A lot of prevention for maternal mortality, we end up with the same mortality, even though we get a lot of prevention things into place. It's when we looked at mortality data, it was about half of all the cases were unpredicted. Now, some of that may be that we could identify earlier and some not. But what is absolutely critical is that the other half, they had emergencies that required interventions, often surgical, and they were not able to get it. And that has much improved in the region. And it's because there's been a heavy effort to make it that we have obstetricians or people that can do obstetric care, more importantly, available in more peripheral areas. I think that's the best answer that I can give at this point, but I can go in. If it would be okay, could I also answer the last question just very briefly, because I got one simple thing to say on it.
Of course.
Every stakeholder has the thing for them that's important. And what we have to do is to find what that thing is and then frame what we have within their thinking. And so it was a great question from Dr. Peterson. And I think that is a bird's eye view as to how we can address with each of these different groups. Thank you.
Would anyone else from the panel like to comment on obstetric care? Dr. Herman, thank you.
Kia ora again. I think just from a Pacific perspective, if we think of surgical services with obstetrics and anesthesia, and given this is a strategic meeting, if we're thinking about a game of chess, we actually have many of the ingredients or tools already in place. I say this with a view that we need to look outside the box, pretty much outside the region, to Australia and New Zealand, where right now we have key surgical leaders across the 3 specialty areas sitting in Australia, New Zealand, and not necessarily just in the Pacific region. And until, and I think having the Pacifica Medical Association sitting in New Zealand, which Kiki chairs, and Debbie Sorensen, who's online as well as the CEO, I think is an excellent positioning of strategic partners to connect the whole system in the region as well as across. For bigger countries in the region, like Fiji, Papua New Guinea, it could be self-sustaining, but for smaller countries, we do need that kind of assistance. So for the Cook Islands, over the past 2.5 to 3 years while I've been there, we've really implemented strongly the use of diaspora. We already have health specialist visits coming to most of the Pacific region countries, but for the Cooks, we are tapping into surgical intellect using remote, and COVID has also forced us to do this. And we're getting access to good information, decision-making processes across the clinical spectrum for not just the 3 big ones we're talking about today, but other specialty areas. And I think we need to start thinking not just about building in country, but also linking to the rest of the world, and also our own Pacific leaders that are sitting outside the country. So perhaps when I speak about, talk about the workforce becoming more efficient, that's one of the options as well to make sure. And right now, if I can just, without saying too much, but we have Dr. Ted Hughes now seconded to the Cook Islands Ministry of Health. Right now, we have a very sick patient getting medevac to New Zealand via Tonga. So thank you, Tonga, for allowing that plane to land in Tonga. And this person is very, very sick. And the only, Ted Hughes works in Waitemata District Health Board, North Shore, and Auckland. And so it's these connections that need to get strengthened and given the ability to help countries much more faster and efficiently. Thank you. Oh, may I just mention also, while we focus a lot here on surgical services and PISA, Pacific Island Surgeons Association, we also have the Pacific Reproductive Health Society, which is obstetrics and gynae, which also collaborates with our equivalent Australasian faculty. We have the Pacific Island Surgical Anesthesia Association as well. So I think, again, back to the role of PMA to help connect the institutions or the professional organizations with RECs, with other not public health, but the others. I think those pieces are all in place. Our job now is connect them and also get each country to have their plans that are linked into the regional framework that WHO has just published. Thank you.
Thank you, Dr. Herman. Kay, would you like to field the next question for the panel?
Sure, happy to. So first, thank you for turning on your cameras. It's great to see everybody's faces, and some familiar and some new faces. It's great. The other thing is I just wanted to remind the speakers, some of the questions, you are able to see them on the Q&A, and feel free, if you're comfortable multitasking, typing your answers while you're listening to us at the same time. We encourage maximum interaction during this session. So right now, I want to go to Sabrina Duran, if she's here. She's from UNFPA, and she has a very good question. Sabrina?
Thanks so much, Guy, and thanks to all the panelists for the very insightful presentations. Indeed, yeah, I work at UNFPA, the UN Sexual and Reproductive Health Agency in Latin America and the Caribbean, and I already learned so very much from all of you today that I would actually really like to see reflected in our region here. So I would like to share a couple of thoughts and two questions. So the imperative of achieving universal health coverage is clearer than ever. Right? And it's the path to sustainable development and to a faster and better recovery from the pandemic. But now every action and every investment that we make in line with the 2030 agenda and the ambition of leaving no one behind really needs to go first to those who are most at risk of being left behind. Right? So a first step is to reach and empower marginalized groups, and so they know how to claim their rights. And then, since the most excluded groups also then face common challenges, we must pursue structural changes that unlock common benefits and opportunities. And so my first question to the panelists, how do we envision to identify those most at risk of being left behind first? And how do we then target our interventions accordingly to really have an opportunity to impact those people at the margins of society? And then my second question is, building back better from the pandemic requires prioritizing adequate resources for health services, right? And we see a lot of competition and resources, and we see a lot of reallocation of budgets as well, right? Priorities are constantly shifting and they're being moved from one area to the other. And so my second question, my last question to the panelists, how are we going to integrate surgical obstetric anesthesia care in efficient and effective reconstruction strategies? And again, thank you so much for having me, and thank you so much for allowing me to ask my question. Thanks.
Thank you, Sabrina. Does anyone want to take that question or two questions?
Okay, can I take the first question, Kay?
Please.
I'm just sharing my experience being a national head for the surgical services in Malaysia in 2016. So one of the problems that we have as regards to providing what's priority in terms of service is this communication between the policymakers and the providers. Sometimes there's always not enough avenue for the clinicians to communicate with the policymakers. Sometimes the policymakers think of the problem as how they perceive based on the data that they have acquired. Whereas we as clinicians sometimes look at a different set of data, which is important for us to translate that into what concerns us. So I think the first move to address is to find out the needs. We need to get the right data. Who should be getting the data? Who will be deciding on the data field? See, when I took over to understand the surgical services for Malaysia, the first thing I did was invest time into getting POMR data. Because if you get a good POMR data, it will develop information as regards to area of concerns. Where is your area of concerns? While we talk about access, are we sure that the access provides safety as well? I think POMR data is an excellent data to start with, to advise both us as provider and the policy makers to actually stratify where are the problems, which are the areas. All right, so the answer to your question is good data, the right data, and how is the data translated?
Thank you. If I may add, I think from a Fiji perspective, I think it's about understanding who your marginalized groups are. Because the marginalized groups may be, there could be a core group that's a core marginalized group right around the world, but in different geographical settings and also in different countries, in different societies, there could be another group, another cohort that you need to identify. And that's, for us in Fiji, we've done that. We've identified that our marginalized groups for safe and affordable surgery are those who don't have access, and those who are in the mountains, or those who are in the difficult areas. And so while the population masses are within the urban peri-urban corridors, but they have access. And I think it's about understanding who our marginalized groups are. And you can all, I mean, obviously there's a lot of things we can think about in terms of, whether it's a gender-based thing, but I think it's about understanding really who is your marginalized group. Thank you.
Right, maybe we should move on. You're mute, Key.
Yeah, let's move on to the next question. We have a lot of good questions, Liz. I'll turn it over to you.
We sure do. A change of tack altogether. We've had like a little discussion around education. We know that workforce shortages are critical in the region, and this question, or really posing of the problem, is from Professor Saja, my colleague from Monash Children's Hospital, who runs the simulation education lab there and has been the lead for simulation education in Myanmar. Very, very successful program. Ram, would you like to open this portion of the discussion?
Thanks, Liz, and thanks, everyone. It's a great privilege to be here with you all. I guess one of the points I was trying to want to see what the experience is in the room, but also that there's been a paradigm shift in the way that we deliver education, especially with simulation-based education. Certainly it's been applied in many settings in low middle income countries, but very much centered in on the technical aspects as well. But simulation has much wider aspects, including non-technical skills, interprofessional dealings, team working, situational awareness and leadership, all of which are vital to improving surgical care. And in fact, actually improve surgical care and the delivery of surgical care far more importantly than the technical skills of the surgeon involved in the actual procedure. I was just wondering about what the view was in the panelists and whether they have experience in this. And just a plea maybe to, when we do progress through, to use simulation and other novel techniques that are coming through to really maximize the educational and the clinical impact, especially in low resource settings, because it can actually be very low cost, but also have a very high impact as well. Thank you.
Anyone like to respond to Ram's question or discussion?
Yeah, simulation will have to be the way forward. I guess with the challenges here in the Pacific, with so many countries coming into Fiji for their postgraduate training, we now have a cohort of surgeons right across the Pacific that have been well trained. They've been trained here with the program, and they're back in their own countries doing a marvelous job. Not only in terms of from the training that they've had and the exposure they've had overseas, but in terms of the leadership that they provide. And I think that is something that, certainly from a Fiji perspective and working with the university, this is something that we want to encourage. But locally within Fiji, we have, the three other, the large hospitals and also the small bellwether capable hospitals that we are forming. We now have a large cohort and a critical mass of surgeons that we have in these areas that have been trained. And we have to be able to work with the providers to be able to look at simulation training and pushing our trainees over into these spaces, because certainly that will have to be the way forward. And I think we have to be also mindful of the fact, and I like this. Somebody had said this in the previous meeting that I was in, is that in terms of the critical care for COVID-19, surgery and surgeons were in the midst of it. We need initiatives supporting critical care. We need surgical PPEs. We need obstetricians providing that. So I think it brings to the fore the importance of actually integrating surgery, obstetrics and anesthesia in terms of the training moving forward in a simulation mode, but at a cold face, rather than having to come back into town like we used to do before. Thank you.
This, yeah, thank you very much. And as I mentioned before, this is a very good question. But at the moment of our development and our moving forward with this NSOC process, training is there all the time. At the moment, we are concentrating on getting the various stages of this process up to scratch. We have the political leadership, We have the situational analysis, with the stakeholder meetings, where obstetrician, gynecologist, everybody in the hospital got in with the minister and the CEO and us. Simulation will be there all the time and will come. But in this process, I made a plea. We need to focus on this. We need to focus on this, otherwise we lose the momentum of this process. And other niceties of the training and things will come on, will be there all the time. Thank you.
Thank you, Lord Tangi. It's a question about training from Dr. Basil Leodoro in Vanuatu, who asks about, given the current COVID situation and our in-country workforce shortages, whether more training could be offered locally for not only for master's students but also for nursing staff. Would anyone like to respond to that?
Liz, do you mean training locally in Vanuatu?
Yes, yep.
Well, we will understand the problem now, but people will come to do the training, will be quarantined for 2 weeks. And we'll do this. At the moment in Tonga, we are involved in Zoom meeting and training all the time. From our colleagues in New Zealand, from Australia, and from Harvard. So to my to Basil in Vanuatu, it's ongoing, and this is the benefit of this COVID as I see it now. People are not traveling, but Zoom meeting is on all the time, and we're doing more training. There are resources available from our partners, and we're doing more Zoom meeting and training all the time. Thank you.
Key, are you ready for the next?
Yeah, so I see that a lot of the questions are being answered directly on the Q&A. This is great. So do we have a multi-dimensional interaction going on? I do want to sort of bring up the issue of anesthesia and task shifting in the region and how each country is approaching that issue. So maybe we can start off with maybe Nepal. Is Bikash, are you still there?
Yes, I'm here.
Yeah, hi Bikash. Just we wanted to have a little bit of understanding of how Nepal is trying to approach the anesthesia component of the surgical system.
Okay, so here in Nepal we have adopting two systems. That is, one is the government is sponsoring, giving scholarship for the doctors who are going to study higher for anesthesia. And in task shifting, as you know, that Nepal has more than half of land with mountain and hilly area. So that there, in the primary hospital, the surgery is being done nowadays. So the staff nurses and paramedics are being trained for the anesthesia, and they are now called the anesthetic assistants. So from those anesthetic assistants, we are providing our surgical care. So the task shifting in the sense of anesthesia in Nepal, we are doing like this. That means sponsoring the doctors for the higher education and paramedics and nurses for the training of anesthesia assistants.
Thanks, Bikash. Does anyone else want to take that question of any ideas about scaling up anesthesia services concurrently?
Key, probably I would just like to share how we do it in Malaysia, especially in the Borneo areas, especially in Sarawak and Sabah. You see, as far as Malaysia is concerned, you have East Malaysia and West Malaysia. Majority of the population is in West Malaysia, very few in East Malaysia. So a lot of services for East Malaysia comes from the doctors from West Malaysia. The problem about sending doctors to East Malaysia is their work-life balance. All right. So sustainability of workforce is a challenge in places, remote places where you have to send them where they want to come back again. All right. So workforce distribution has always been a challenge. So what we have done is come up with, I think this anesthesia program for Sabah and Sarawak was nurse-based anesthesia delivery. All right. So in district hospitals where it's so difficult to reach, the anesthesia is actually provided by nurse anesthetists. We have a special training program. We actually privilege them for a certain number of procedures based on the safety standards. All right. So in the context of cases like cesarean section, the actual anesthesia is delivered by the nurse anesthetist in places like Sabah and Sarawak because the nearest place is just too far. All right. But when you come to East Malaysia, where we have more facilities and more people, in certain districts, the anesthesia is provided by the medical officer, all right, who has been trained and privileged. And yet in the urban areas, the same kind of cases, anesthesia is given by the specialists. So what I'm trying to say is, based on our resources and based on our safety standards and training, we can actually improvise by not depriving care. I think one of the problems we have in the different countries is setting standards too high, unable for us to achieve. I think each country have to have their own understanding of what is available, what they are capable of doing. And I think at a national level and international level, we should participate and contribute to upskill and upscale services that can be provided. My humble opinion is I think we are capable of doing a lot, but sometimes local agenda is so difficult to achieve. You might prefer authorities from an international platform to endorse, facilitate, and assist in translating all these approaches to deliver healthcare.
Thank you, Dr. Yusuf. I see a number of anesthesiologists and nurses, on this panel, participants. I'd like to go to Wayne Morris. He's with the World Federation of Anesthesiology Societies, I think, WFSA. Am I saying it right? Wayne, do you want to chime in on this issue?
Sure, thanks, Key. Can you hear me?
Yes.
So I was just listening to Dr. Yusuf's comments, and I think one of the key things from the WFSA's point of view is that different countries need to come up with their own workforce solutions. And from also from the WFSA point of view, we think that it's very difficult to develop good anesthesia services unless you have leadership from specialist anesthesiologists. And I'd like to refer the people listening to this teleconference to the WHO WFSA International Standards for a Safe Practice of Anesthesia. This is a document which has been endorsed by WHO, and we really hope that this document is being used by countries when they are developing NSOAPs. One of the most important things about this document, and I think this speaks to Dr. Yusuf's point about standards being set too high, is that it offers a graded approach to the development of anesthesia services. So that's the WHO WFSA International Standards for a Safe Practice of Anesthesia. Thank you.
Thank you, Wayne. We've had a great question from Dr. Craig McLean regarding the role of climate change in affecting delivery of surgical anaesthesia services. And sorry, I've just lost it. I'd like to direct this to Dr. Wanganabete first up. Can any of the panelists comment on what steps need to be taken in terms of building climate change mitigation and sustainability into developing surgical systems?
Yeah, thank you, Liz. I just want to begin by saying that, Fiji, we cannot change our coordinates. We are locked in at the 180 meridian. And because we are locked in the 180 meridian, and just like many other small island development states, cyclones and disasters come our way. And, there's nowhere else to run. And I think from a bigger perspective, we have to understand that, and this is the fight of our lives. Small island development states about climate change, and the fact that we can keep on advocating about the nexus between climate change and health. And the nexus is not only limited to the public health component, but also we have to think about the effect that it has on surgery. A lot of the data are talking about how small island development states and countries are being affected because you don't have enough space to be able to plant nutritious food. You don't have the space to be able to create parks and walkways for people to be able to exercise and reduce NCD. So there is a nexus, not only in terms of communicable disease, but also more importantly, non-communicable disease. You've also got to remember that a lot of the communicable diseases that happen in small island development states, their complication, their end stage requires an operation. So if somebody's got a typhoid and it's got a typhoid enteritis and you rupture their gut, they need to have a small bowel out. So you also have to remember that we have to be interested in the complications of communicable disease and climate sensitive diseases. And having said that, from a building back stronger, building back better, from a Fiji perspective, we are very interested in all our facilities, not necessarily just the hospitals, but also in terms of schools, for example, in building back better. We have Cat 5 cyclones come through. We've had 3 Cat 5 cyclones within the last 5 years. And, we realize that we just have to keep on building stronger in making sure that our facilities are functional after a cyclone. And that's what we've done. So with our EMT, emergency medical team of the FEMAT, we've actually embedded not only the public health component, the clinical component, so the surgeons, the anesthetists, the obstetricians that go out. We also have embedded what we call the logistics component. And these are the people, when they get to a place, they set up a tent hospital. Their role specifically, the plumbers, the carpenters, the electricians, is to go to the nearest facilities and make them functional. Because you can see houses being blown up, but you also have to remember that the health facilities, they've also suffered. So it's making sure that we deal with them, make them functional, and also moving forward as we build back better is making sure that we be able to put the money in. And again, if you think about it, there's always a question about, do you build a building that is so strong and green, but is very expensive, or do you build something that may not be as strong, but is less expensive? From our point of view, we want what's strong, but it's costing us a lot. So again, any development partner out there who wants to support us, please feel free to direct message me. We'll be more than happy to take you on.
Thank you, Wanga. Dr. Herman, would you like to comment?
Thank you. I think this is one of the biggest threats facing the Pacific region. And thank you, Honourable Minister Wanganabete, because he's highlighted pretty much all the threats that we have facing us. So I think we talk about resilient health systems, and that includes infrastructure as well. And there's quite a lot of work already happening in this space, led by WHO in particular. And we talk about WASH, and this is with making sure that we've got good IPC systems, sanitation, water, and so forth. And as we know, in many of our impoverished settings, less resource settings, access to clean water is still a struggle for some. And so what I always look back to now with COVID is that COVID has reminded us about the importance of IPC, making sure we're washing our hands, basic public health, and that goes right across. And I think the other thing around this in terms of sustainability is really looking out at what we use for energy production. So some countries are already solar powered, and especially the smaller Pacific Island countries. I think Tokelau is already solar powered. The Cook Islands is pretty much solar powered in the smaller islands, and there's just one more island to be solar powered. So I think there's quite a bit of progress in that. What we can't change is our geographical placement and the fact that we are at risk of cyclones and so forth. and also rising sea levels encroaching and intruding into our water storage spaces. So I think there's a lot of other things though that we know we can do something about. And I think I've just highlighted some of them. The other thing, of course, is with water. We know that with climate change and its impact, we're going to start running out of water. And our ability to make water, whether this is through desalination, is going to be critical, because in surgical services, you need good, clean water. You need good, clean equipment, sanitized equipment, and health professionals that are not going to be spreading infection to other patients. So there's a lot that needs to be done, but a lot already happening in this space through our development partners, including New Zealand and Australia. Thank you.
Thank you, Amir. And Dr. Sal, one final comment on this topic.
Thank you very much. Yes, I wanted to make two small points. One is that just to follow up on the issue of wash-in facilities, we have a publication that looked at 150 hospitals across the entire region. And we found that most hospitals in delivery rooms, in postnatal wards, and in NICUs, we found most of the rooms had sinks and most of those had running water. When you start looking at availability of soap and it decreases quite significantly. And then when you look at ways to dry your hands hygienically, it drops down to 10 to 40%. So if we're trying to prevent infections, the starting point is a pretty simple one in that regard. Now that was prompted by the previous speaker, but I just now want to go take the reverse of the question. We contribute, the health system contributes a huge amount to air pollution, to environmental degradation, especially when we don't segregate waste and treat them and treat infectious waste and things like that. The contribution is something like between 8 and 11%, depending on which indicator you're looking at. So moving toward being green is an absolutely critical side that we can do as our contribution to prevent climate. I don't even want to call it climate change. That's a PR term. Global warming is what it is. If we are going to stop global warming, we also have to contribute by doing a better job of making our facilities so that they're not contributing to this and our practice is not contributing to that. I just wanted to add that point. Thank you.
Thank you, Howard. Keith.
Yeah, so we're already at 10:55. Man, time really flies. And there were so many excellent questions that remain unanswered. There were some great questions from surgical residents, medical students, nurses, perioperative nurses, but we just don't have the time. But we will try to, we have the questions. We'll somehow try to communicate those questions to the panel and try to get back to you. But at this point, I would like to turn over to Dr. John Mira for closing comments. John?
Thank you, Key and Liz. Thank you so much for moderating this. This was fantastic, wonderful 2 hours. And Salman, I want to thank you and the Center for Global Health Delivery. So kind of you to sponsor this, and all the panelists and speakers today. Just an incredible group of people that came together for this. And I can't do justice, obviously, to summarizing this incredible 2 hours just in a few minutes, but it struck me how much has changed even in 5 years. This type of a meeting would probably not have occurred a number of years back. And the things that we're seeing happen in ministries of health, we wouldn't have seen a number of years ago. And that's really because of all of you on the panel and all of the attendees. And it speaks to something that Lord Tanguy said, which is, we are going to be making these changes. We're going to be educating politicians. We're going to be changing political priority. And all of you have been doing that. And the Asia Pacific region has certainly been leading the way in this, and it provides a wonderful example for the rest of the world. So I feel like the momentum has really pivoted and changed a lot, even since 2015. So that's a credit to all of you. So on one hand, sure, now maybe we're not the neglected stepchild and we're, surgery is more recognized, and that's fine. My concern is that we still don't see funding flows changing a tremendous amount, and I'm very concerned about that. And just so happens that session number 2 is going to be about financing for surgical obstetric and anesthesia and trauma care. I think that's really important for us. To a large degree, the momentum and the narrative has changed, but I still don't see capital flowing towards this. So I look forward to our next webinar. I think we're going to tackle that problem. Not to say that we've solved the political prioritization process and there's more work to be done, but I applaud the Asia Pacific region for really showing tremendous leadership. So thank you to all of you, and have a good morning, afternoon, or evening, depending on where you are. Thanks.